And we will move to the next speaker. معانا I don't know it will be live ولا recorded lecture مع Professor محفوظ الشهاوي من United States.
Okay, do you hear me?
سمعت إن هي لايف. سمعت إن هي لايف.
You
He's currently live.
Okay.
what do you think?
So Dr. Mahfouz al-Shahawy, Professor Mahfouz will talk about pre-hypertension is a disease.
Now, do you hear me?
Yes, we hear.
Okay, and I think I can use my slide here if you want. I can put my slide on, see that you will be able to see that in your end. Okay. Can you see the slides?
Yes, we hear your voice, sir, but we don't see your slides.
No, I have them up here because I think here having the camera, the video at your end is not having it open. Maybe share here.
Okay.
Okay, that's no, that's not. Okay, share.
Everything is clear now, sir.
It's clear.
Yes, we can start.
All right. First, hello from Florida. I'm sorry I couldn't be with you in person, but I congratulate all of you for this excellent program, and particularly thanks to Dr. Makladi and Jamila Nas and Mohsen Ibrahim for the invite. Now, I will not view the restraint on the time and the lateness of the hour dwell too much. I will just try to emphasize the few most important points which might be of interest to you and something might be new on that matter. So now, having said that, pre-hypertension is a disease associated with significant structural and functional cardiovascular abnormality. The message to take with you home today that really even the number of the blood pressure we currently saying that should be treated will be probably soon in the future in view of some of the new data we're finding in the pre-hypertension already evidence-based medicine, we might have to lower that number. This is our hostel, and you are more than welcome to visit anytime, one of top 50 in the country. Disclosure form, quick few questions. Normal blood pressure, according to the current American guideline 2022, should be, I will answer quickly, less than 120 systolic and less than 80 diastolic. That is the number you have to keep in your mind. Now, what is pre-hypertension, elevated blood pressure? Is it a disease with structure and functional abnormality? Yes, and that is based on evidence-based medicine from data we have already published from our center. Now I will refer it to you shortly. Now, hypertension is the leading cause of this. All of you know that. SPRINT trial results showed significant cardiovascular risk reduction in diabetic patients with hypertension. This is a tricky question. In the SPRINT trial, there was no diabetic patient. That's the reason of some criticism. But regardless, all of us know that we have to treat diabetes optimally. This is a statue in our city, similar like that in San Diego, California, that can bring your high blood pressure up. Now, we know that significant advances in our knowledge about intervention to prevent cardiovascular disease have occurred since the Framingham Heart Study, which started in 1948, concluded 58, and 10 years risk score. But since then, we have learned that you can have all these risk factors and still you might not have a problem, and vice versa. Regardless, now we are looking for an evidence-based medicine. So what is pre-hypertension? What is the effect on the cardiovascular risk? High normal blood pressure actually was already studied in the Framingham study. 6859 participants in the Framingham study had pre-hypertension and was found to have more cardiovascular events by the end of the study. So, but what is the evidence-based medicine? We have learned that the higher the blood pressure, whether male or female, the higher the risk will be. That's when the optimal blood pressure, normal blood pressure, high normal blood pressure. So the purpose of this presentation actually we have reported previously that blood pressure and the type of testing we have been doing, a special exercise protocol, which is very simple, and you can start doing in your office tomorrow, and you can gain a lot of information. How it is done. Patient on a treadmill stress test at 2.4 miles per hour, 7% elevation, and for 3 minutes, normal blood pressure rise at this exercise workload should not exceed 30th. However, those who have more than that have already, by the data, the study which we have done and the test we done, and I have reported that earlier at the Egyptian Society of Cardiology, and Dr. Mohsen Ibrahim, my good friend, have been aware of that and have asked a question on it. So I will discuss that briefly. Basically, we have already seen that the carotid intima media thickness increase. We have seen that there's small vessel C2 at increase. So increase in the blood pressure at this exercise workload is a very, very nice point. And guess what? If you have normal patients, normal tensive, and you put them on the tread machine, how many of these will get the abnormal rise? About 18%. If you have pre-hypertensive patient, how many of these will have the abnormal rise? Over 39%. And guess what? Those who do have the abnormal rise in the blood pressure, those who do have the abnormal structure and functional abnormality, i.e., carotid intima media thickness increases, the microvascular abnormalities increases, as I will show you on our data. So I think in the future, it might be a very simple test to do to get the patient who you question about the high blood pressure, does he really need to be treated or not? And the one who have rise in the blood pressure after 3 minutes, that's the one maybe you should be treating. So that maybe the calcium score of the blood pressure will be to use in the future. So having said that, what is the study population? We have studied 2,233 asymptomatic subjects. Here is the normal group. Out of this was 855. Pre-hypertensive was 942. The demographic in both groups was the same, including, look here, the blood pressure 110, this 127. Look what? They all have the same other risk factor, the same, or the HDL, LDL, smoking, etc. So they were very well selected and compared. Now this is a group, I added hypertensive group. You don't need to talk about it here. Now, the test here, the time will not permit me to go over that in detail, but this is the test we're using, 7 vascular tests, large artery, C1, small artery, C2, blood pressure at rest and post-mild exercise, carotid intima media thickness, eye background retina photography, abdominal aorta, and macro. This is the vascular test. Cardiac, ECG, left ventricular ultrasound, ProPNP. And we have the scoring system based on that. And the scoring system, if you have, for the heart, of course, we have electrocardiogram, cardiac ultrasound, and BNP. Now, we did all this test in addition the blood cholesterol, the blood sugar, the CRP, if you get less than 3 points, you're low risk, medium risk, high risk, early risk. This is evidence-based medicine. So you cannot argue with that like you can argue with the relative Framingham risk study. So here is the reminder about the blood pressure category. Now, as we said before, normal, less than 120, less than 80, elevated, pre-hypertensive, less than 80 diastolic, stage 1, stage 2, systolic or diastolic. Just a reminder. Now, here is the data which might be of interest to you, and in interest time, I will go quickly to the slide, the group here. The normotensive group, the untreated, the 596, the pre-hyper 521, all have the same demographic, except for the blood pressure. Had the blood pressure rise abnormal. If you have normal blood pressure, out of this group, only 18% had abnormal rise in the blood pressure, 24 have abnormal carotid endothelial thickness, 21 CMT. If you're pre-hypertensive, look that, you find that you have, if you have normal response, you get only this one 61%, 39%. The CIMT was 41%. So CIMT, abnormal rise in blood pressure, whether pre-hypertensive or normotensive with abnormal rise, you get abnormal CIMT. And all of you have heard about the importance of the CIMT in relation to stroke, and blood pressure is one of the major risk factors for stroke. So the C2 also abnormality. So structural and functional abnormalities have been noted in patients with pre-hypertensive with abnormal rise in the blood pressure, more so than if you are normotensive. So maybe a small, cheap test, do the exercise stress test and decide which one, if you have in question, whether you treat or you should not treat. Pre-hypertension is a prevalent disease, exceeding normotensive. Structural and functional cardiovascular abnormality are more pronounced in pre-hypertensive as compared with normotensive, with average 39 versus 26. Abnormal blood pressure rise post mild exercise is associated with more cardiovascular structural abnormalities in pre-hypertensive subject as compared with subject with normal blood pressure rise post mild exercise. Abnormal blood pressure rise more common in pre-hypertensive as compared with normotensive. Abnormal rise in blood pressure is associated with preponderance of C2 abnormalities compared with those without blood pressure rise. So blood pressure rise, which you are under all day, when you walk around, that is really what blood pressure should be done. I think the way we're checking blood pressure is unphysiologic. You get the patient, sit down, be quiet. That's not what he's under all day. And so that's what I hope in the future there will be a change on the way we manage blood pressure, check blood pressure, and judge blood pressure. That is very, very important. The structural abnormality in pre-hypertensive subject with abnormal blood, particularly statistically significant. Based on our data, pre-hypertensive found during screening tests may justify at least mild protocol exercise stress test, like I told you, on a treadmill at 2.4 miles per hour, 7% elevation, 3 minutes, and normally should not exceed 20 millimeters of mercury. This group who get higher than that, that's the group which absolutely need to be treated if you are in doubt. Based on our data, clear evidence of early cardiovascular disease, CIMT and C2, and abnormal rise post mild exercise was present in pre-hypertensive subject. Abnormal rise in blood pressure was the most common abnormality noted, followed by abnormal CIMT and C2. Also, you might consider, actually in the future, and maybe starting tomorrow in your office, everybody who walks in check the blood pressure is normal, but he's at risk for developing high blood pressure. Get a mild exercise test on him, and you will see if his blood pressure does not shoot up 20 points, then it's fine. It's good. But if it does, then this is the one you might have to consider to follow up and even treat. So it's time to change the way we practice and what to do. Back in the 03, Paul Wilson said treatment or risk factor rather than the disease. That was a new approach for health, which you fully agree. But today, you say plus that, plus even in the absence of cardiovascular risk factor, an asymptomatic subject utilize accurate tools to assess evidence for early cardiovascular abnormalities, including subclinical atherosclerosis, i.e. CIMT and others, which must be treated aggressively to avert or delay morbid cardiovascular event. This must be the new approach to world health in the 22nd century. Time to adopt simple protocol exercise stress test, like I'm saying it again, and that will really better than the calcium score test, which we used to assess whether the patient should be treated or not with a statin. That may be whether this patient should be treated or not for high blood pressure. That is time to focus on simple tests for screening, and not just like this lady say, I am smoking, nothing happened to me. Remember risk factors for cardiovascular disease, enhancing risk factor, I call them the A, B, C, D, E, F. A, hemoglobin A1C, B, blood pressure, hypertension, C, cholesterol, another C, cigarette smoking, D, diet, obesity, E, exercise, and F, family history. Remember that, and as I said earlier, you need every patient. If you have a simple blood pressure, nothing else associated with that, you might think about whether to treat or not. But the more risk factor, as have been shown in Mr. Fit, more risk factor you add, the more higher risk, the more you need to treat. And this is to show you that the machine we use for the pulse contour analysis, which he cleared, and we use that for them, how we assess the pulse wave, and the clinical pair subclinical atherosclerosis in pre-hypertensive asymptomatic subject is far from being incidental finding. It is at the very heart for several cardiovascular event. There are several simple gold standard tools to carefully assess and monitor the disease. Early detection, early detect to protect, and treatment has a profound positive impact on common comorbidity and can reduce the cardiovascular event. Subclinical atherosclerosis in pre-hypertensive subject is far from being incidental finding. It is at the very heart for several cardiovascular events. That's the reason I say in the future, I have a gut feeling that the number for blood pressure will be changed, and what we're calling today is pre-hypertension is really be defined as hypertension. Now, as he says sometimes, how low should you go with your blood pressure? Say as long as you can stand straight and you don't faint. There are several simple gold standard to carefully assess and monitor the disease. Early detection and treatment has a profound positive effect or impact on morbidity. Take-home message, early cardiovascular disease, enhancing risk factor, including pre-hypertension, which is then to progress and result in cardiovascular, can now be early recognized by non-invasive testing, which the time did not allow me to go over that all in detail, but I gave you one of the simple tests we do. Now, medical management must shift its emphasis from treatment of advanced disease to early prevention early detect to protect. Medical management must shift the emphasis. Early therapy aimed at this project could drastically reduce cardiovascular morbid event in the 22nd century and reduce the cost of healthcare. Cardiology, all healthcare providers really should be in the business of cardiovascular disease prevention. One thing I heard you talk about today but I did not hear much emphasis about. The sad part is most of the doctors, including in the United States, do not check blood pressure properly and delegate it to the least podium for blood pressure. American Heart have recently put a pamphlet with 10 points. If you don't follow this 10 point, you get screwed up number. What are these 10 points? Some of them sitting in the chair, quiet, leaning back, not crossing your legs, have your arm free, don't talk to anybody, empty your bladder before that. If you do any mistakes of this, you'll get a wrong blood pressure number. So blood pressure must be taught and must be exactly measured correctly. So we have to be all to be a preventive healthcare providers. And thank you. And I will be more than happy to answer any question you might have.
Thank you very much, Professor Mahfouz Shahawy. And we have a question from Dr. Suleiman Gharib. For Dr. Suleiman.
Dr. Shahawy, thank you for your elegant talk. I am Dr. Suleiman Gharib.
Okay,
if you remember,
Dr. Gharib, how are you?
I'm fine. I think you have back to year 2007 when the expert panel from Heart, Lung and Lung Institute say that the normal blood pressure is 115/75. And this can explain that the pre-hypertensive part began from this period. And they stated that after the 115/75, all the complications of hypertension can occur, including the renal trouble and renal abnormality. Therefore, I think your finding is support this finding, which dated back to about 15 years ago. Am I right?
You are completely 100% right, correct. As a matter of fact, some of this data I just talked about were presented at the annual meeting of the American Heart in 2012. At that time, when they were starting to talk about changing the guideline, and I urged them at that time to please, because they were thinking about putting a higher number than 140, which was the guideline at that time. I told them, please look to a lower number. Here we're having a problem, even what we call pre-hypertension. So you are completely correct. Any other questions?
Dr. Mahfouz, how are you? I'm Gamila Nasr, and many thanks to you. Very elegant, as usual. Thank you very much.
Dr. Gamila Nasr is an
yes,
icon.
yeah.
We should clone you. You're incredible, Dr. Gamila.
Thank you. Thank you, sir. Thank you very much. I'm just asking about the genetic phenotyping. Do you think, does it have an important role for prevention?
Yeah. Let me go back for the because that's a very interesting and a good question. There have been some data coming out here about the genome, and actually it has to do now, they're coming to the expressed genome. So that means is the nature load the gun. The gene is already loaded already, but the environment changes. That the modified genome, not everybody who have a gene for hypertension, for example, family history, will be modified. The surrounding, the modifiable gene, that is really the new testing going to be. If the environment so bad, that again emphasis about the environment, how it can affect the gene, and you get modified genome, that for hypertension, that will be the one. If you happen to be lucky enough and the environment does not touch you, or all the crazy thing around you, that probably you will not. But genetic is still in early stages, but the concept of the modified genome, not only just for hypertension, for anything else, is going to be taking a big place and will be the test in the future.
Thank you.
Thank you, Dr. Mahfouz, for having you today. Just may I ask you a very brief question? With a current lack of well-validated tool for risk assessment, especially in those cohort of pre-hypertensive patients, do you recommend, based on your data, that those pre-hypertensive patients, we can perform for them some stress modality by whatever protocol to segregate who may need starting some medications?
That is an excellent question. That's what I was trying. Maybe I was fast going through that. What I said is when I showed this table with the group of patients who are normotensive and the group who are pre-hypertensive. And we did this various 18 different tests, which I have discussed at your meeting many years ago. And Dr. McLady and Dr. Master Ibrahim asked me, I remember vividly questions on that. Anyway, so the ones who have the abnormal rise on the blood pressure after this very simple, straightforward exercise stress test, i.e., the treadmill machine going at 2.3 or 2.4 miles per hour, 7% elevation, 3 minutes. Normal subjects we don't treat them, 82% of them did not have the abnormal rise in the blood pressure. However, 18% of these have that. In the pre-hypertensive group was 39% right. So I think this cheap test, rather than the 18 different tests which we are doing now and cost a lot of money to do, might be just the answer. Just the answer, like when you have the lipid and you have a question the intermediate risk group and you wanted to see whether they give statin or not, you get the calcium score, picture better than 1,000 words. And if the calcium score positive, you move into the statin side. If the negative, fine, I don't have to push it. Same thing here. I will do the exercise stress test. I might even do the 6 minutes walk. I have not done that, but I think that might be another idea to move this patient for 6-minute walk around and see what happened to the blood pressure. But our protocol, which have been validated by Jay Cohn from the University of Minnesota and published that, have already found those who get the abnormal rise in the blood pressure, the one who have most the structure and functional abnormality. So that's the one which, to answer your question, which I will treat, I will follow also very carefully. See, Dr. Garib, remember, just think about it. Now we checking the blood pressure on this patient under very unphysiologic circumstance, condition. Sit in the room, quiet, and do all this thing, and we treat him on that. But that's not what I'm under all day. I'm outside, walking around, doing things. What's my blood pressure then? And that might be what the exercise test telling us.
Thank you very much, Dr. Mahfouz Shahawy, and we are looking to see you very soon, inshallah, in Egypt.
Inshallah.
inshallah, قريبا جدا.
Thank you very much. I appreciate the invitation. I appreciate your question. Have a good day and good meeting.
Thank you very much.